Thank you very much. I hope you have some energy left for another session. This time we're going to talk about congestive heart failure and left-to-right defects. Okay, so it starts with a quick overview of congenital heart disease. We'll talk once again about pulmonary vascular resistance. We'll go into the clinical feature of congestive heart failure in children, and then start to talk about all the lesions that are characterized by left to right shunts. So atrial septal defects, ventricular septal defects, patent ductus arteriosus, atrioventricular septal defects, and coarctation of the aorta. So once again, a full schedule. So let's get started. We'll start with the overview of congenital heart disease. The incidence of congenital heart disease is about 4 to 9 per 1,000 live-born infants. And in the USA, every year about 32,000 babies are born with heart defects, worldwide 1.5 million. We now know 35 different congenital cardiac defects, and I feel that the cardiologists come up with a new one every year. Currently, we have about 1 million patients living amongst us with congenital heart disease, among them 300,000 children under the age of 21 years. At least 38% had at least one or more cardiac surgeries, and the death rates declined dramatically over the last couple of decades. And nowadays, 85% of infants are expected to reach adulthood, which means they will go to school, they will play sports, they will ride the bikes, they will come to our ERs and our hospitals, not only for cardiac surgery or cardiac cath procedures, but also in the trauma bay when they fall off the couch, or they come from for dental rehab. So every one of us, not just cardiac anesthesiologists, we all have to have a basic understanding of how to take care of these kids that present either with unrepaired or with repaired congenital heart disease. And that's why this lecture is so important. Okay, I don't expect you to be able to read this table. This is just a little reminder that our friends from cardiology tend to use their own lingo. They have a lot of abbreviations that are very unfamiliar to us, and it's often hard to read a cath lab report or even an echo report. And what I would like to recommend to you is either have a little card with these abbreviations in your locker room or on your smartphone or somewhere where you can just pull it out and look it up. And if you can't figure out the pathophysiology, don't understand the surgery that had been done, pick up the phone, call the cardiologist, or discuss it with the cardiac surgeon. Communication is really important here. The cardiologists, they often follow these families and the kids for many, many years. And they are well versed, they know exactly what the lesion implies, but they are not familiar with the changes of that surgery and anesthesia, what positioning means, what a prone positioning implies, what the afterload reductions after induction of anesthesia means, all these things, the fluid shift. So you really have to discuss every single case with the cardiologist to make them aware of the potential dangers of anesthesia and surgery. So please communicate with the perioperative team. Here's the question for you. A 7-year-old boy with Williams syndrome presents for an elective brain MRI under anesthesia. Which of the following statements best describes the potential cardiovascular involvement in this patient? A. It is most often associated with subvalvular and valvular pulmonary stenosis. B. It's commonly associated with endocardial cushion defects. C. It is an arteriopathy involving mostly the supravalvular ascending aorta, often including coronary ostia and coronaries, but also other arteries. D. The severity of the cardiovascular disease is easily assessed by a preoperative echo. What do you think? 7-year-old boy with Williams syndrome. Okay, good. You're right. Very, very good. So A is what most likely would be the Noonan syndrome. B is most likely the trisomy 21, right? And D is wrong because that is, we'll get to it in a second. But it is really important. The preoperative echo can be normal or does really give you a false security. You can't assess the coronary involvement with a preoperative echo. It's the wrong test. I'm stuck. Okay. Once again, I don't expect you to be able to read this. This is just a little reminder that many, many syndromes are associated with congenital heart disease. And If you are not sure about it, then look it up in a list or in a handbook, but be aware of it. 25% of children with congenital heart disease have at least one, if not more, extra cardiac malformation. And this here is just a quick summary of the most important one. So you have chromosomal syndromes. Trisomy 21 is the most important one, the Down syndrome. 50% of the patients have canals, AV septal defects, VSDs, tetralogy, or a PDA. Trisomy 18, the Edwards syndrome, often associated with VSDs. Trisomy 13, the Pateau, with PDA, septal and valval defects. The Turner syndrome, aortic coarctation, a bicuspid aortic valve. The gene deletion syndrome, the Williams syndrome, as we just discussed, very important, is the coronary arterypathy that can be not detected in an echo. You can't really know how their coronary involvement is if you just have an echo. So you got to be careful and always assume that they have the worst coronary artery disease that you can imagine. The 22q11 deletion syndromes, DiGeorge, the velocardiofacial syndrome, the Spritzen one, so-called catch-22, cardiac abnormalities, abnormal faces, thymic aplasia, cleft palate, hypocalcemia, hypoparathyroidism, catch-22. Single gene defects, the Noonan, our first answer, 50% most of the time have dysplastic or stenotic pulmonary valves. They also have hypertrophic cardiomyopathy. Marfan syndrome, mitral valve prolapse, dilation of the ascending aorta. And then you have the associations like the factal, the vertebral, anal, cardiovascular, tracheoesophageal, renal, and limb anomalies, or the Charge syndrome, coloboma, heart defects, conal atresia, retardation, and genitourinary ear abnormalities. So remember, when you see a kid with congenital heart disease, be aware that they can have other anomalies. Okay, another question for you. Which of the following congenital heart defects is least likely associated with a left to right shunt? A, the coronary sinus defect. B, a partial anomalous pulmonary venous return. C, tetralogy of Fallot with pulmonary stenosis, or D, a perimembranous VSD. Oops. Okay, so tetralogy of Fallot with the pulmonary stenosis, you are absolutely right. That's the most common cyanotic lesion that we have, and this is a right to left shunt. All the other ones are left to right shunts. Okay. Brings us to the classification of congenital heart disease. You can classify them just by appearance. Are they blue or are they pink? Cyanotic versus acyanotic. And then you can start looking at them. Do they have right to left shunts, like tetralogy of Fallot, pulmonary atresia, or tricuspid atresia? Are they complete mixing lesions, and that's why they are blue, like the transposition or the total anomalous pulmonary venous return, truncus, a hypoplast, or a double outlet right ventricle? Or are they obstructive lesions? And if they are pink, are they left to right shunts, or are they obstructive lesions? Some find it easier to classify the congenital heart defects according to the common pathophysiology. So you would look at patients that have more of a volume overload, either by left to right shunt, at the atrial, ventricle, or level of the great vessels, ASDs, VSDs, canals. Or is there obstruction to systemic blood flow? Could be ductal dependent, critical aortic stenosis, coarctation, interrupted aortic arch. Is there obstruction pulmonary blood flow? Critical pulmonary valve stenosis, tetralogy. Is there parallel circulation where you have to mix between two separate circulations, like in a detransposition? Is it a single ventricle physiology? It's a very heterogeneous group. Or are these primary myocardial disorders? They can be primary or acquired, all the cardiomyopathy. So this helps some people to classify and kind of make sure that they understand what's going on. If all this fails, and this is just such a complex lesion that you really can't figure out what to do, then I go back to a very, very simple approach. And believe me, it helps. Imagine you are a red blood cell, okay? This is you. And then ask yourself the following questions. How will I get through the heart? Is it easy or do I have to struggle? Will I be able to pick up oxygen? How many of my friends will carry a load? I'm the only one. How many times do I have to swirl around before I can get back out? Is there a shortcut or a detour? Is it different if I come from the upper or the lower extremity? I know this sounds crazy, but believe me, they are still very complex lesions where I sit there, just close my eyes and think how I get through the heart, if I take up oxygen or not, if I go there without oxygen load, if I'm the only one. Sometimes this is the only way to make sense out of very complex lesion. All right, brings us now to shunt terminology. You will hear a lot about restrictive shunts. They have a very small orifice of communication and large pressure gradients across. So the size of the orifice, the size of the hole determines your shunt flow. On the other hand, we have non-restrictive or what we call dependent shunts. You have a large hole where the pressures on both sides of this communication are equal, and the shunt flow through the orifice is really dependent on the respective outflow resistances, your pulmonary and your systemic vascular resistance. That is what determines your shunt flow. We talk about simple shunts, which means these are just holes like an ASD, VSD, and they don't have any additional obstruction. And complex shunts, if you have additional outflow obstructions at various level, because this then makes this whole SVR, PVR ratio a little bit different and influences it in a different way. So that's what you have to think about when you talk about shunts. Back to our favorite topic, the pulmonary vascular resistance. And here's a question for you. A 5-month-old baby girl with trisomy 21 and an unrepaired complete atriovenous canal defect is undergoing an emergency laparotomy for a bowel obstruction. She had been fully saturated before induction of anesthesia, but is now increasingly cyanotic. Which of the following factors is least likely to contribute to an increased pulmonary vascular resistance? Is it A, hypoxia? Is it B, atelectasis? Is it C, light anesthesia? Or is it D, hypocapnia? Very good. You all nailed this. So this is how you manipulate your pulmonary vascular resistance. Factors that increase your pulmonary vascular resistance is a PEEP, high airway pressure, atelectasis, low FiO2, acidosis, hypercapnia, and increased crit, if your crit is 55 or 60, sympathetic stimulation, light anesthesia, pain, agitation, catecholamines like epinephrine, dopamine, direct surgical manipulation during the dissection phase, and vasoconstrictors with phenylephrine. And then all the other ones are decreasing your pulmonary vascular resistance. What about the SVR? How can you manipulate your systemic vascular resistance? Well, once again, increased systemic vascular resistance with sympathetic stimulation, pain, catecholamines, norepinephrine, phenylephrine, ketamine, negative intrathoracic pressures, and hypothermia. Whereas fever, sepsis, positive pressure ventilation, vasodilators, and adequate sedation and analgesia decrease your SVR. How do children in congestive heart failure present? What is different compared to adults? And here's another question for you. A 2-month-old male infant born at term is presenting with a 3-day history of projectile vomiting. He has a loud holosystolic murmur and was recently diagnosed with a large membranous VSD. Which of the following signs and symptoms is least suggestive of congestive heart failure in this infant? A birth weight of 3.2 kilos, and the weight at 6 weeks is now 3.5 kilos, sweating during feedings, C, a respiratory rate of 60 to 70, or D, bounding pulses. Which one of these signs and symptoms is least suggestive of congestive heart failure in this infant? Okay, very good. Up. All right, we got to work a little bit on this. So D, the bounding pulses, is the right answer. The birth weight of 2.3 kilos and the weight at 6 weeks of 3.5 kilos. So that is, how much weight should you gain during the first week of life or during the first 6 weeks? So usually for the first week, you lose about 10% of your birth weight, but then you regain it. And afterwards, you gain about 30 grams per day. So in a week, that's about 210 grams. So this baby basically gained in 6 weeks what he should have gained in 1 week. So that's a poor weight gain. And this brings us now to I explain it in a second with the next slide. So back to the pathophysiology of the left to right shunt. You have pulmonary overcirculation. Increased pulmonary blood flow usually starts when the pulmonary vascular resistance starts to decline 6 to 8 weeks of age. We talked about this in the previous lecture. You have increased pulmonary artery pressures and a left ventricular volume overload from the pulmonary circulation. It just swirls around and swirls around. And it doesn't get out to the systemic circulation, so you have congestive heart failure, low cardiac output, and pulmonary edema. If this persists for a long time, you see changes in your pulmonary vasculature. Remember the picture that I showed you? Initially, it's just vasoconstriction in a response to the increased blood flow, but then the vessels start to remodel. You develop what we call the pulmonary vascular occlusive disease, this thick muscular layer. Initially, this is reversible. Later, it's fixed. And the end stage is a shunt reversal, the so-called Eisenmenger syndrome. Now, instead of a left to right shunt, you have a right to left shunt and develop significant cyanosis. So how do kids in congestive heart failure from left to right shunt look? The classical features are the failure to thrive, the poor weight gain. They feed very difficult. They sweat, they have frequent pauses. In order to finish a bottle, it takes them an hour. Mom said, I don't know, but they're always sweaty. They don't gain any weight. They have frequent respiratory infections. They have cool and mottled extremities. If you watch them, they breathe very fast. They're very tachycardic. They have a cardiac murmur. The heart is big on X-ray. They have a big liver that you can palpate, often rails when you auscultate them, and they are poorly perfused and have a prolonged capillary refill. These are the clinical signs of congestive heart failure in children. The murmur thing is kind of tricky, right? 90% of children will have a murmur sometime in their life. And how often do you get a child in the pre-op clinic and there's a murmur? So what do? A lot of them are called innocent murmurs, right? They're pulmonary flow murmur, there's so-called still murmur. It's a very musical murmur over the left sternal border. They can be physiologic pulmonary branch stenosis or a venous hum or a carotid brome. So how do you differentiate them from real significant murmurs? So here's a few pointers. A characteristic innocent murmur is never diastolic or never continuous. They are very low in the intensity. They always have a little bit of a musical component. They are never associated with an abnormal cardiovascular exam. So if you have a palpable thrill, it's not an innocent murmur. Something is wrong. They are very soft and they have a systolic ejection type, and they change with position or with loading condition, or if you see the child, a fever has a murmur, and once the fever is treated with Tylenol, it's gone, or the anemia is treated, and that is kind of an indication that it's more likely an innocent murmur. How easy is this to assess? Well, it's not that easy. EKG and chest X-ray won't help you. Even cardiologists are only able in 95% to detect if this is a significant murmur. You really need an echo to get 100% detection, and that's a costly diagnosis. But keep this in mind. The only way to really rule out that this is anything but an innocent murmur is to use the echo. Okay, pathophysiology, back to our right to left shunt now instead of the left to right shunt. So if you have right-sided obstruction and a connection between the right and left shunt, you shunt right to left. You have a decreased pulmonary blood flow, develop hypoxemia and cyanosis, and you develop RV hypertrophy and disjunction, and most likely arrhythmias later in life. A problem with the right to left shunts is that these kids are significantly cyanotic, and they develop a compensatory polycythemia to maintain adequate tissue oxygenation. If you have a kid that is blue and has a saturation of 70, but a crit of 38, this child is anemic, because this child is supposed to have a crit of 45 or 50. So if you see this kid, you can bet on it that it's either severely malnutritioned with a poor weight gain or has iron deficiency anemia. So work it up. The problems with the cyanosis, I mean, it's a good compensatory response, but the problems is that it leads to significant hypoviscosity and poor rheology and problems in the microcirculation. When the crit approaches 60 and 65, they are actually at risk for spontaneous thrombus formation, and they can cause microembolization especially subendocardial, and they cause ischemia later in life. They can be associated with brain abscesses and strokes from this hyperviscosity, and also very common in cyanotic kids are coagulopathies and platelet dysfunction. It's important to note that dehydration or prolonged NPO status are very, very dangerous. If you have a kid that starts off with a crit of 50 or 55, and you now put this kid on 12 or 15 hours of NPO, the crit might go up to 65 overnight, and they might have a spontaneous stroke. So some of these kids you have to admit overnight and rehydrate, or you have to have very responsible parents that you talk to them and make sure that they wake the kid up in the middle of the night or early and give the kid additional fluid so that you don't have a completely dehydrated kid with a crit in the 65 level in the morning. And by the way, try to put an IV in. All right. How do you evaluate the cyanotic newborn? And this is a slide that I put in because it was on the exam. It was twice mentioned and I couldn't believe it. But the evaluation of the cyanotic newborns, the neonatologists still start with the so-called hypoxia test. And what is this? It means that you do an ABG and then you repeat the ABG after breathing 100% FiO2 for 10 minutes. And then you see if your PO2 actually increased. If it increased, if it responded to oxygen, it's most likely a pulmonary disease or a ductal-dependent pulmonary blood flow, and there's some lesion that can be falling into this category. If it doesn't respond to oxygen and your PO2 stays low, and you don't have an increase in your saturation, you don't have an increase in your PO2, then you have likely a cyanotic cardiac disease or a very large intrapulmonary right to left shunt. You look at the chest X-ray, is there pneumonia? Is this a diaphragmatic hernia? Do you have a big pneumothorax? Look at the ECG. Is this a right versus a left hypertrophy? And then you get an echo. But in most small community hospitals, it will take a while for them to get an echo. It takes half an hour, an hour. So this is what the neonatologists use initially before they have to echo to establish the real diagnosis. They also look at the differential saturations in the arterial line. Is the preductal saturation or the preductal oxygen level higher than postductal in the umbilical? And then if in doubt, they will always start them on prostaglandin E1. All right. And this explains this a little bit more. So you do the hypoxia test and you establish that the PO2 didn't rise. Now you ask yourself, do you have a differential cyanosis? Are my saturations in the right hand, the preductal ones, higher by over 10% than in the lower extremities? If no, look at the chest X-ray, see if there's an intrapulmonary shunt, a pneumonia or pneumothorax. If you don't have any focal changes, start PGE1, and then look again at the chest X-ray. Do you have poor vascular markings or normal vascular markings? And it will tell you if you have a pulmonary outflow obstruction or complete mixing lesions. Now, let's say you have the differential diagnosis and your sets are higher in the right hand than in the lower extremity. That is an indication that you have pulmonary hypertension. Now you have to decide, is it the usual one, that the pre ones are higher than the post ones, or is it reverse? So if it's the usual one, once again, look at the chest X-ray, any evidence of a blunt lung injury, meconium aspiration, congenital diaphragmatic hernia, or the persistent pulmonary hypertension, the lung injury. If you have no focal changes, then start PGE, look at the chest X-ray again. Is the heart big or is it not big? It will give you evidence if it's more of a systemic outflow obstruction or pulmonary venous obstruction. And if you have the rare occasion where your post-saturation is actually higher than your pre-ductal saturation, then you can bet that you most likely have a TGA with pulmonary hypertension or coarctation. And you didn't use an echo at all. So that is the poor man's, the neonatologist, primary way of trying to sort out what is wrong with a cyanotic newborn. So remember, hypoxia test, it was twice mentioned in the last exam. Differential diagnosis or cyanosis, the saturations in the right hand, the head, and the neck are higher than the rest of the body. Usual differential diagnosis is a PDA with pulmonary hypertension or a PDA with preductal coarctation. Right to left shunting via the unrepaired PDA. Your saturation, that's what it looks like, and the fingers are 92 and the toes 84. What you also see on the picture is marked clubbing. and the crit is 65 in this patient here. Reverse differential cyanosis, when the sets in the right hand are lower than in the feet. Your big differential diagnosis, a D-loop transposition of the great arteries with pulmonary hypertension or an interrupted aortic artery coarctation. It can happen in supracardiac TA-PVR with preferential streaming, but this is now really a colibri. Obstructive lesions, left or right-sided isolated obstructions. You have a pressure load on your respective ventricle, which leads to a significant hypertrophy and increases your O2 consumption. If critical, you have a decreased cardiac output and tissue perfusion, metabolic acidosis, your lactate levels goes up, you have decreased coronary perfusion, your ventricle fails, you have arrhythmias, and you die. In the neonatal period, often enough, the pulmonary or the systemic blood flow, dependent where the obstruction is, can be maintained via PDA. And these kids all of a sudden will deteriorate once the PDA closes. And the first thing that you do is you start them on PGA and prevent the occlusion of the PDA. So this is what we call ductal dependent lesions. The other form that we discussed is the complete mixing lesions. When your venous and your arterial blood mix at various levels. And this happens when you have single ventricle physiology. There's only one ventricle, and the systemic venous return and the return from the pulmonary veins all mixes in this one ventricle. Or in a transposition where you have two separate circulations and they have to mix somehow. Often enough, the situation is complicated by extra cardiac flow obstructions, coarctation, subpulmonary stenosis, and things like this. But otherwise, in mixing lesions, we talk about a parallel circulation. So basically, your adequate tissue oxygenation and perfusion depends on a well-balanced pulmonary and systemic circulation. Only when as much blood goes to the lungs as goes to the body, then you can survive. If you have pulmonary overcirculation, you have poor systemic cardiac output, you get significant acidosis, and you die. Or you have poor pulmonary circulation, you are cyanotic and acidotic. So the goal is to have a well-balanced circulation where your saturations are about 85% and your mixed venous saturation is about 60%. This would be a well-balanced circulation. How do you evaluate cardiac hits? And this is another busy slide, so I apologize. But it all starts with the history. Try and figure out how symptomatic they are, if they have the signs and symptoms of congestive failure, failure to thrive, recurrent pulmonary infection, decreased activity level. If they have palpitations or syncope, if they have additional congenital anomalies, especially airway and renal abnormalities. Get their recent and current medication, specifically diuretics, digoxin, ACE inhibitors. Review all their previous surgeries and the interventional procedures. And then last, do a follow-up with the patient's pediatric cardiologist. When did they last see him? What did he recommend? What is the issue? The physical examination, we discussed it. Is there a heart murmur? Is there precordial thrill? Do you hear arrhythmias? How do they breathe? How do you hear any rales? How is their peripheral perfusion? How are their pulses? How are their extremities? Where is the liver? Do they have any edema? Look at the CBC. What is their crit? Are they polycythemic because they are cyanotic? Are they anemic because they have malnutrition? What about the electrolytes and the coagulation profile? A lot of cyanotic patients have coagulopathies, so make sure that you get a coagulation profile. Additional tests, you look at the echo, the EKG, and the chest X-ray. And if you are lucky, they had a recent cardiac catheterization with the anatomy, pressure gradients or saturations, or even a cardiac MRI that gives you further ideas about the anatomy and pulmonary blood flow. So these are all the things that you can look at. Some of the kids also have a Holter monitor, so if they are prone to arrhythmias, or might have an exercise test that gives you an idea what they tolerate as regards heart rate and blood pressure. So when we talk about definitive repair, things that really fix the underlying problem, you have to differentiate between the so-called anatomic repairs and the physiologic repairs. And anatomic repair means that we have a left ventricle that is the systemic ventricle, supports the systemic circulation, and the right ventricle that is the pulmonary ventricle, supports the pulmonary circulation. Your circulation is in series, which means the blood goes first to the pulmonary circulation, returns to the heart, and then enters the systemic circulation, and you are not cyanotic. This is an anatomic repair. Can be a simple reconstruction. You have a hole in the heart, like an ASD, a VSD, or a shunt connection. You put a patch in or you clip it. Otherwise, a structural normal heart, you shouldn't expect any late complications. Or you can have very, very complex reconstruction with baffles and conduits and valves where you know that they can calcify, obstruct, and you have to think about late complication and that they might come for further surgery. Then we have what we call the physiologic repair, where the circulation is in series, so the blood goes first to the lungs and then returns to the heart, and the cyanosis is corrected. But even if you have a two-ventricle repair, now, like in the situation of a mustard or a Senning, the atrial switch, your right ventricle is the systemic one, and the left ventricle supports the pulmonary circulation. You might say, so what's the problem? Well, there is a problem. As it turns out, the right ventricle is not made to support systemic circulation for a lifetime. The muscle bundle arrangement in the right ventricle is made for only supporting low pressures. And if this right ventricle has to support systemic pressures for a long time, they are prone to fail. So over time, they will get progressive RV failure. It doesn't matter how good the repair otherwise is. And then the other physiologic repair is the single ventricle repair, the Fontaine, where you basically only have one ventricle that has to do all the work. Obviously, that can lead to significant problems later in life. All right, what are we talking about when we think about a palliative repair? These are temporary repairs that improve the situation a little bit, but they are not really fixing the underlying problem. They are used to treat severe cyanosis, to improve pulmonary blood flow, or to restrict pulmonary overcirculation, and they are usually parts of staged repairs. Shunts, PA bending, or like the Norwood procedure is a palliative repair. Nowadays, we have to mention something else, the interventional cardiac catheterization repairs. They do a lot nowadays in the cath lab. They close ASDs and VSDs with devices. They place or balloon dilate and place stents in valves and coarctations. They coil embolize and they coil collaterals. They do atrial septostomy. The problem is that these patients don't have a scar that could alert us, and most of the parents and the patient, they don't take these interventions really serious. They only spent one night in the hospital. It was just a procedure. It's nothing out of the ordinary. So you have to specifically ask them about a recent intervention. Because for us, it's a red flag. If you know that they had recurrent recent interventions, you know that there is a residual problem. So please make sure that you ask all your cardiac patients, when was the last time in the cath lab and what did they do? Okay. Now let's start looking at specific lesions. We'll start with the atrial septal defect. And what is an atrial septal defect? Well, it's actually isolated, only 5 to 10% of congenital heart disease, but it is often part of complex defects. We have several types. There is an osteosecundum one. This is the one in the big one here. Where's my mouse? Oh, here we go. Right there, the ASD2. That's the most common one, located right in the fossa ovalis. Then there is the ostium primum one, right over the atrioventricular valves. That is often associated with a cleft in the mitral valve and some form of mitral regurgitation, so that's a little bit more complex to repair. The sinus venosus one, either up here in the SVC or sometimes occasionally in the IVC area, that is often associated with a partial anomalous pulmonary venous return. And then occasionally you can have an unroofed coronary sinus, which is another form of an ASD. The underlying pathophysiology, guess right, it's a left to right shunt. It leads to slowly progressive RA and RV dilation, but is usually well tolerated. Only later in life you will develop pulmonary hypertension. A lot of the ASDs, up to 80%, will close spontaneously, especially the small ones within the first 2 years of life. So that if these kids are asymptomatic, we just watch them and they get repaired later on. Signs of symptoms, most patients are asymptomatic. They're often just incidental finding, a routine exam, or they have some arrhythmias, or later in life they present with a paradoxical embolization and a stroke. Large untreated ASDs, occasionally later in life when the patients are in their 30s and 40s, can lead to significant pulmonary hypertension. Classic, back from medical school, wildly split and fixed second heart sound, and a little bit of a systolic murmur. Virtually any congenital anomaly can be associated with an ASD. How do you treat it? You don't really have to do anything there. You don't have to restrict the exercise. They don't need endocarditis prophylaxis, as we discussed earlier. Some of them can be closed in the cath lab. They have to be a suitable anatomy. They have to be an adequate ring to be able to to close them this way. And otherwise, they are done surgically when they don't respond to medical treatment and when they are symptomatic or they are too small for a device. Otherwise, electively in children around 2 and 5 years of age to prevent long-term complications, stroke, arrhythmias, and Eisenmengers. The procedure is a median sternotomy, direct closure with a patch, or sometimes you just have to put one suture stitch through, either by an atrial approach and a mini incision, so it's just a partial, or occasionally they do a full sternotomy. What do you have to think about when you have a patient that comes with an ASD? Well, remember, they are at risk for a paradoxical air embolus, so be careful, make sure that you have bubble precautions, an air filter, or make sure that you don't have any air bubbles in your lines. They have a higher incidence of perioperative dysrhythmias, so don't be too surprised if you see a few extrasystole strokes on your monitor. You can easily do an inhalation induction that's usually well tolerated. If you do a mini sternotomy for the surgical repair, make sure that you understand that you have poor access to the heart and you have to have the defibrillator pads on because you often can't get the direct pads on. They often fast track and there's no need for prolonged ventilatory support. If you have a patient with repaired ASD in the first 6 months, if they come for dental rehab, you gotta give them endocarditis prophylaxis. They have a potential for arrhythmias, and the longer they were unrepaired, the more likely it is that they develop arrhythmias. So there's a study out that showed if you had your repair before the age of 11, you only have a 4% chance basically of developing AFib flutter later in life. If this was repaired beyond the adult age, when you're 40s, you get 60% chance of developing AFib flutter. So the longer you have an unrepaired ASD, the more likely you are to have arrhythmias later in life. Sometimes you have persistent RV dilation. It takes a while to remodel, or even pulmonary hypertension if it was a late repair. What about VSDs? That's a little bit more significant. VSDs are the most common congenital heart defects that we see. So 20 to 25% of all defects are ventricular septal defects. Once again, 30 to 40% close spontaneously within the first year of life. So if they are not symptomatic, you sit tight and wait. There are several types. The most common one is the perimembranous one, right here. And there's an outlet one that's just beneath the pulmonary valve. There's an inlet one that's a little bit posterior and inferior. And then you have the muscular one, the Swiss cheese one, 5 to 20%. So the second common. They are often very difficult to find. So pathophysiology, once again, a left to right shunt, pulmonary overcirculation, congestive heart failure, poor cardiac output. They are in over 5% associated with other anomalies, most of them chromosomal, so watch out for trisomy 13, 18, and 21. Signs and symptoms, small VSDs can be completely asymptomatic, so these are the kids that you just watch. Infants with a large VSD usually present with congestive heart failure at the age of 6 to 8 weeks when you have the second decrease in your pulmonary vascular resistance. You have a holosystolic murmur and often a systolic thrill like at the left sternal border. How do you treat them? If they have congestive heart failure, you put them on ACE inhibitor, diuretics. Occasionally you will still see a child on digoxin. Some of them can be closed in the cath lab with a device, but most of them will end up in the OR, especially when they're unresponsive to medical treatment, or if they have a very large left to right shunt with QPS of over 2 to 1. Elective repair is done in asymptomatic children around the age of 2 years, once again to prevent long-term complications. Occasionally, in sick infants that are unable to tolerate a cardiopulmonary bypass, we do a palliative PA banding first and let them grow and let them recover from their recurrent illness, and then we do the definitive repair, a patch closure, later on. This can be either done via an atrial approach, or especially if you have these multiple Swiss cheese one, sometimes you have to do a ventriculotomy, which then has a problem because now you created a scar and the risk for arrhythmias. So how do you deal with VSDs? Small VSDs with no obvious congestive heart failure. You can do a careful inhalation induction and you just got to be aware that they might have a slightly reduced cardiac reserve. What about the ones with a large VSD and significant congestive heart failure? Well, we prefer an intravenous induction, aiming for a stable pulmonary vascular resistance SVR ratio and normal ventilation. Be aware that if you start hyperventilating, oh, I'm so glad I got the airway, I'm fine, and have them on a high FOA2, you can actually decrease your PVR and then increase your left to right shunt, and the next time you run your blood pressure, you don't have any blood pressure anymore. So be aware that you have to adequately normal ventilate. You can kind of break yourself a little bit. Don't go crazy with the ventilation. Reduce your FiO2. They also are at risk for shunt reversal, either when they are severely hypotensive or when you have sudden increase in your PVR, so the bucking infant coughing against the tube when you wake them up. What do you have to think about when you have patients with repaired VSDs? Endocarditis prophylaxis for the first 6 months after the patch repair, if they come for dental or TNAs. Are there any residual defects? Is there a hole close to the stitch or something like this? They often have conduction defects. They often have right bundle branch plaques or ventricular arrhythmias. The classical complete heart block is, thank God, a very, very, very rare complication. You can have ventricular dysfunction, especially if they had to cut in the ventricle or if they had severe pre-op congestive heart failure. And then if the repair was late, or you have syndromes like trisomy 21, or you go on one of these missions and work up in high altitudes, then these kids might present with pulmonary hypertension. Patent ductus arteriosus, another one of the left-right shunts. It's a normal fetal structure, connects the main pulmonary artery and the upper descending aorta, functionally closed, usually 10 to 15 hours after birth, but it's very common to be open in preterm babies, and then you have to either treat them medically with endomedicine, and if this fails, they come to the OR for closure. So the degree of left to right shunting depends really on the size of the PDA and of the PVR to SVR ratio. Small PDAs are often hemodynamically insignificant and asymptomatic. Medium ones present with a left to right shunt as soon as the PVR falls, and large PDAs are often significant because they lead to progressive congestive heart failure. So sudden increases in your PVR can reverse your shunt once again, and you can be significantly cyanotic. How do you diagnose it? The continuous machine-like murmur at the left sternal border, signs of congestive heart failure, and the widened pulse pressure with low diastolic pressure. That's the Steele effect. And that's important to know because that's why the neonatologists send you the preemie, because they are worried about neck, they are worried about the Steele effect, the low diastolic pressures, that they get not enough blood flow to the intestines. Associated anomalies, think about the ductal dependent defects. A lot of defects need the ductus for adequate pulmonary circulation or systemic circulation. So all these listed here, coarctation, interrupted aortic arch, critical aortic stenosis, hypoplastic left heart, TGA, critical PS, they all depend on the ductus for either pulmonary or systemic blood flow. And then preterm infants, I already said, they go into severe respiratory distress, or they develop intracranial hemorrhage because of the Steele effect. How do you treat it? Preterm infants usually have a trial of endomedicine. Otherwise, you treat the congestive heart failure and the edema. If the child is older and not mini preemie, you can go to the cath lab and close it with coils, especially if you have residual shunts sometimes. Otherwise, you go to the OR. And you do a ligation via posterior lateral thoracotomy. In older kids, you can do this with a VATS, a video-assisted thoracoscopic surgery. Watch out. There is the recurrent nerve that's there that you can injure, and they can have a vocal cord paralysis. So what are your anesthetic considerations? Make sure that you have pre- and post-ductal pulse oximetry to make sure that you can detect if they clip or digate the wrong vessels. You want to have upper and lower extremity blood pressure monitor, once again, to determine pressure gradient and make sure that they don't clip the wrong vessel. When the PDA is closed, your diastolic pressure should immediately go up and your murmur should be gone. This is nice when you have an esophageal stethoscope in. You can actually hear immediately that the machine-like murmur is disappeared the moment they put the clip in. Older children, when they do a VATS, they might actually ask you to do a lung isolation. Preterm infants, this can often be performed at the bedside in the NICU, which is for us an off-site anesthesia with all the off-site dangers and problems. You have reduced monitoring options, poor access to the patient, and a limited backup. So make sure that you bring all your emergency drugs, your vasoactive medications, and blood that you have immediately available. The position of the endotracheal should be checked and carefully secured, especially when you turn the kid a little bit can lead to main stem or even easy extubation because it's only a few centimeters in. The surgical exposure and retraction is basically a functional single lung ventilation, and some of these kids are very, very difficult to manage, especially if they have pre-existing respiratory distress. All right, what do you have to think about when you have a kid that comes back with a repaired or after a repair of the PDA? Once again, if it's in the first 6 months, then after the device closure and they come for an appropriate procedure, got to think about endocarditis prophylaxis. They can have a recurrent laryngeal nerve injury and vocal cord paralysis, and they can have still some pulmonary hypertension and ventricular failure if this was repaired late in life. All right, moving on to the atrioventricular septal defects. So this is the endocardial cushion defect. Classical, we have several types. We talk about a partial AV canal when you basically have just the ostium primum ASD and a cleft in the mitral valve, but otherwise two separate, nicely formed AV valves. They talk about a transitional AV canal if you have a primum ASD and one common big valve orifice with bridging leaflets, but functionally you can actually see there's a separate mitral valve and a tricuspid valve, and you only have a very, very small inlet VSD. The complete AV canal is defined, you have a big primum ASD, there's one common AV valve orifice where you can't define what is what, and you have a large or moderate VSD. And then we talk also about an unbalanced AV canal. This is when this orifice of the AV valve is directed towards one ventricle and the other ventricle is basically hypoplastic. And these are considered single ventricle lesions and they have to go down the single ventricle pathway. What's the pathophysiology? Yes, you guessed right. It's a left to right shunt, but also significant AV regurgitation plays along because you don't have competent AV valves. They early on develop pulmonary overcirculation and congestive heart failure and get early onsets of the pulmonary vascular occlusive disease and pulmonary hypertension. They develop congestive heart failure very early on. You have a holocysternic murmur. And the associated anomalies to remember is trisomy 21. Also cardiac anomalies. You can have a tetralogy follow-like canal type or a double outlet right ventricle canal type. And DiGeorge is occasionally associated with canals. So potential difficult airway, hypocalcemia, immunodeficiency, and need for irradiated blood. How do you treat it? Well, initially you treat the congestive heart failure with diuretics, ACE inhibitors, and then usually anywhere between the age of 2 to 4 months, sometimes earlier, if they don't respond to medical therapy, you bring them in for surgery. The PA bending is no longer recommended. It ended up with a higher mortality, so you try to do the surgical repair. You close the ASD, VSD. Some people do it with one patch, some people do it with two patches, and then you carefully have to reconstruct the AV valves. The complications are the mitral valve regurgitation, sinus node dysfunction, and because you put a VSD patch on and you're very close with your stitches to the conduction system, you can cause a complete heart block, and they might have come back later for a pacemaker. What are the anesthetic considerations if you have children with a canal? Well, number one, you have to have all the implications that you have with trisomy 21 patients, right? Potential for cervical spine instability, a large tongue, short trachea, difficult vascular access, the early onsets of your pulmonary vascular occlusive disease. You have a very large left to right shunt, so they act like a large VSD. So if you have severe congestive heart failure, it's preferable to do an intravenous induction, once again aiming for a really stable PVR-SVR ratio, and once again avoid hyperventilation and high FiO2. Restrain yourself, normoventilate them. The same thing happens like in a big VSD. If you all of a sudden increase your PVR or you're severely hypotensive because you cranked up the SIVO to 8%, you risk the shunt reversal and all of a sudden you have a very deeply blue kid. TEE is especially beneficial to assess the mitral valve function, but be careful in these small kids. If you put the TEE probe in, you can get some respiratory compromise. Sometimes you compromise the trachea or one of the bronchioles. So whenever you put the TEE in, check that your ventilation is still okay. Often they require inotropic support and some pulmonary vasodilators. And these kids, because they had high pulmonary artery pressures, are at risk for pulmonary hypertensive crisis and arrhythmias, especially in the immediate perioperative period. So be aware. You have to be very careful when you suction them after bypass. Keep them deep. Make sure that they are adequately hyperoxygenated. Okay, what do you have to think about in patients that come back after a canal repair? Look at the echo. Make sure that you understand how much residual mitral regurgitation they have. What about their pulmonary hypertension and their RV dysfunction? Is it completely gone? Are they recovered? And do they have any arrhythmias, sinus node dysfunction, or a complete heart block? So this is what you have to look out for. Okay, next one. We're almost there. The coarctation of the aorta. Question for you. A 4-hour-old newborn with persistent cyanosis is diagnosed with congenital heart disease. For which of the following defects is a prostaglandin E1 infusion least beneficial? Hypoplastic left heart syndrome with aortic valve atresia, pulmonary atresia with intact ventricular septum, a truncus arteriosus type 1, or a severe neonatal coarctation. So for which of the defects is a prostaglandin infusion least beneficial? Okay, you got this all right. Very good. We mentioned before, hypoplastic left heart syndrome, pulmonary atresia, and severe neonatal coarctation are the so-called ductal-dependent lesion, and it's very important to start prostaglandins while they are waiting for their surgical repair. Okay, coarctation of the aorta. That's 5 to 10% of all heart defects are coarctations. There is a wide spectrum. They can present as a discrete stenosis or a long segment. They can be preductal, where the PDA is really important to maintain the perfusion to the rest of the body, or postductal, and these kids have often significant collaterals. It's important to remember that there are a lot of associated defects with coarctation. 50% of them are cardiac. They can be part of a hypoplastic left heart syndrome, or they have a VSD. 85% of patients with coarctation have a bicommissural aortic valve, and they later in life can develop aortic valve stenosis, so they need a lifetime of follow-up. 25% have other malformations. They have Turner, or they have muscular, renal, or GI syndrome, and very important, 3 to 10% have berry aneurysms and are actually at risk for subarachnoid hemorrhage later when they're in their 30s and 40s. And our adult cardiologists are fully aware and actually monitor them very closely for this risk. You have two major clinical presentations. They present as infants with severe coarctation, which is often preductal, so they're ductal-dependent lesions, and they present with congestive heart failure and low cardiac output because of the significant pulmonary overcirculation and edema if they have a large VSD. As I said, ductal-dependent perfusion to the lower body. They get tachypnic, they don't grow, they have a big liver, they have metabolic acidosis and poor perfusion. So if they don't present as infants, the second major clinical presentation is the child or the adolescents with mild to moderate coarctation. And these are the kids that in school or prior to some sport event that they're going to participate, they go in for their physical exam, and someone noticed that they are hypertensive. And oh, by the way, they have a murmur. They are completely asymptomatic. Sometimes they complain of a little bit of headaches or pain maybe in their leg. When you feel for the pulses, they have decreased pulses in the lower extremities, and they have a major systolic pressure gradient between their upper and lower extremities, but so far they were always flying under the radar. So the asymptomatic child or adolescent is the second presentation. So what do? How do you tailor your anesthetic? Important to do the preoperative evaluation of associated anomalies. What else is wrong with the kid? If you have newborns and infants, they are usually in significant congestive heart failure, and you have to do a careful titrated IV induction. Most of the time it's narcotic-based maintenance because their function is so compromised that they don't tolerate a lot of inhalational agents. All the infants and children, you can do an intravenous or inhalation inductions and maintain them with them. If you do invasive blood pressure monitor, it's the right radial artery that is the important one. The left subclavian artery may be clamped during the repair. There's only one exemption. If you have an anomalous right subclavian artery, then you kind of have to choose which one to choose. But usually stick with the right radial and you're safe. Make sure that you have additional blood pressure monitor and pulse oximetry in the lower extremities so that you can monitor if there's a residual gradient. Large bore IV access, you're working on the aorta. If there is bleeding, it's massive bleeding. And during the cross-clamping, make sure that you use volatile agents and short-acting vasoactive agents, esmolol, nipride, nitroglycerin, to maintain the blood pressure usually 20 to 30 to 40% over your starting pressures to allow for adequate collateral perfusion if you have collaterals. Some would measure the pressure in the lower extremities to keep it over 40 millimeter mercury. And then use mild hypothermia. We usually cool these kids down to at least 34 degrees for neuroprotection. When they declamp, take the clamp off. Make sure you have all your vasoactive agents on. Correct your metabolic acidosis. Have a little bit of bicarb ready and have volume ready to bump the pressures up and be ready for bleeding. Postoperatively, hypotension and the post-correctectomy syndrome are things that you have to watch out. You see it less in the infants, but more in the child and the adolescents, that they get this rebound hypotension and the reperfusion syndrome with abdominal pain and vomiting. And they often benefit from having been placed on esmolol or sometimes dexmedetomidine or nipride to keep the pressures low. What do you have to think about when these patients come back after a repair of their coarctation? Well, number one, they are at risk for recoarctation, for developing a restenosis. And the pressure gradients at rest might be not significant, but when they exercise, they get significant gradient pressures. So sometimes you will see them that they actually do exercise testing to see if the pressure increases during exercise. If not, be prepared that it happens during your induction or emergence that you might see higher pressure gradients. The risk for recoarctation is higher when you had to do a repair in infants. So the earlier the repair was done, the more likely it is that they have a restenosis. So be aware when you get an infant. All of the patients with coarctation have some form of persistent hypertension. It just explains to you that this is an underlying generalized arteriopathy, a systemic disease, not just a mechanical problem. They develop an underlying arteriopathy and they all have persistent hypertension. And you have a myocardial hypertrophy as a residual, but also from the persistent hypertension with diastolic dysfunction, and they are more prone to develop premature coronary artery disease. So these are the things that you have to keep in mind. And don't forget, if you have young adults or patients in their 20s and 30s, berry aneurysm, they might be prone to subarachnoid hemorrhage. And I think with this, and I'm a little bit early, but I think you all had a long day. So thank you very much.